Hi, welcome to our final UWorld FNP QBank Live review session. My name is LaQuisha. I'm one of the family nurse practitioners on the medical content development team here at UWorld. In our previous sessions, we've reviewed the 4 competencies that you'll see on the AANP exam and the ANCC exam, and high-yield image-based dermatology questions. Both of those reviews are still available on our YouTube page, so feel free to review those at your leisure. Today, we're going to be reviewing high-yield heart murmurs and other cardiology questions. We'll be utilizing the UWorld's QBank of animations, videos, audio clips, and images to help drive our teaching points home today. So make sure that you're watching in the full screen mode so that you can see the entire video. Okay, let's get started. Question number 1. This is going to be a diagnosis question. A 19-year-old man is brought in after he passed out while unloading heavy packages from a truck. The episode lasted 30 seconds. Over the past year, he has had brief episodes of lightheadedness related to intense exercise. Blood pressure is 130/75 and pulse is 78 beats per minute. On examination, a 2 out of 6 grade systolic murmur is heard over the left sternal border in the standing position, which is not present while the patient is squatting. There are no audible clicks on auscultation. Which of the following is the most likely diagnosis? Going to give you guys a chance to look at the answer choices. A, aortic regurgitation. B, bicuspid aortic valve. C, hypertrophic cardiomyopathy. Or D, mitral valve prolapse. So the answer to this question is C, hypertrophic cardiomyopathy. So we'll come back to this image at the top in just a second. This young patient has exertional lightheadedness and syncope, a systolic murmur over the left sternal border, accentuated by moving from a supine to a standing position, which your findings consisted with hypertrophic cardiomyopathy. Now, this is going to be an autosomal dominant genetic disorder, and it's very low in the population, maybe 0.2 to 0.5%. So you want to make sure you get any other family members tested that may have this actual condition. It's characterized by left ventricular outflow tract obstruction, which can result from hypertrophy of the upper septum. So depending on the degree of the severity, patients may have no symptoms at all, or they may have fatigue, exertional dyspnea, chest pain, palpitations, pre-syncope, or syncope. Let's take a look at the murmur that you will hear when patients have this condition. Make sure you turn your volume up so that you can hear the audio.
Hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is characterized by enlargement of the interventricular septum. The enlarged septum restricts flow through the left ventricular outflow tract. Outflow obstruction varies with left ventricular volume. Standing causes blood to pool in the legs and reduces venous return to the heart. Left ventricular volume is decreased, which worsens the obstruction and accentuates the murmur. In severe cases, systolic anterior motion of the mitral valve leaflets may further exacerbate the outflow tract obstruction. Other maneuvers that decrease left ventricular volume, such as Valsalva strain phase, will also accentuate the murmur. Squatting increases afterload by compressing the vasculature and causes the pooled blood in the legs to mobilize. There is an increase in venous return to the heart. Left ventricular volume is increased, which lessens the obstruction and decreases the murmur. Supine leg raise and hand grip also increase left ventricular volume and decrease the murmur.
Okay, so that is an example of the UWorld animations and videos that we have to kind of help bring that point home to give you a visual image of what the question is discussing. Now let's take a look at why the other answer choices are incorrect, as we typically do. Choice A, aortic regurgitation. That normally presents with a progressive exertional dyspnea and a high-pitched early diastolic decrescendo murmur on cardiac auscultation that's heard best at the left sternal border. Choice B, bicuspid aortic valve, which is a very common congenital heart disease in adults with aortic stenosis that can lead to exertional syncope, but will typically cause a prominent ejection click followed by a mid-systolic murmur that's best heard over the right second intercostal space. Standing from a supine position would actually decrease the venous return and preload, decreasing the intensity of that murmur. And then choice D, mitral valve prolapse. That usually produces a mid-systolic click with a mid-systolic to late systolic murmur best heard at the cardiac apex. So different locations and different types of murmur sounds. So the educational objective for this particular question, hypertrophic cardiomyopathy is an autosomal dominant genetic disorder of the cardiac sarcomere. It may be asymptomatic and detected on routine evaluation, such as ECG abnormalities, a systolic murmur that increases with standing. Patients may also have fatigue, exertional dyspnea, chest pain, palpitations, pre-syncope, or syncope. Let's move on to our next question. This is also a diagnosis question. A 55-year-old woman has had the sensation that her heart is skipping beats for the last 3 weeks. The patient has had no chest pain, dyspnea, or diaphoresis. The ECG is shown in the exhibit. Which of the following is the most likely diagnosis? So let's take a look at the exhibit, and this is what we're going to use for this question. So I'll give you guys a second to kind of take a look at this lead before we go to the answer options. Let's see if I can pull this down just a bit so you can kind of still see it while looking at the answer options. So we have atrial fibrillation, complete atrioventricular block, C, first degree atrioventricular block, or D, Mobitz type 1 atrioventricular block. And this is the image that you're going to use for that. Okay, so let's click out of this. Give you a couple more seconds to get your answers down. And the answer for this is D, Mobitz type 1 atrioventricular block. Now, there's the second degree atrioventricular block. There's distinguishing features of Mobitz type 1 and type 2. With type 1, the level of block is going to be in the AV node. You are going to see progressive prolongation of the PR interval followed by a dropped QRS complex. And the QRS complex itself is going to be narrow versus type 2, which will be the block will be below the AV node or the His bundle. The ECG findings will be a constant PR interval with randomly dropped QRS complexes, and the QRS complexes themselves can be narrow or wide. So let's pull up this ECG finding here. So as you see, this is what's known as a Winky-Bach Mobitz type heartbeat. You have the progressive lengthening of the PR interval before the QRS drop. So it's like PR lengthening, 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 drop. What's my name? Winky-Bach. That's a way to remember Mobitz type 1 versus type 2. You'll also see that the P wave is not conducted prior to the dropped QRS complex each time. So as you see, progressive, progressive, progressive lengthening. That's going to be the key feature of this particular heart block. So in going to our explanation, the ECG findings best seen in lead 5, as we just saw, show a Mobitz type 1 second degree, or Winky block, atrioventricular block, which is recognized by progressive prolongation of the PR interval followed by a dropped QRS complex. The distance between the start of each P wave is constant. That's that constant P to P interval. Therefore, the PR interval prolongs, the R to R interval progressively decreases. ECG often demonstrates a group beating, which is repetitive grouping of QRS complexes. Example, the drop occurs every 3 QRS complexes, or every 4 is going to be a consistent repetition. The block is usually located within the AV node, and causes include elevated vagal tone, excessive pharmacological AV nodal blockade, such as beta blockers, ischemia, and age-related degeneration of the system itself. Patients are usually asymptomatic, and management just involves observation and correction of potential reversible causes, such as those medication uses. Let's take a look at the incorrect answer choices and some of those images to see the differences in how the strip will be viewed. So choice A, atrial fibrillation, or AFib. There's no organized atrial activity, and impulses are conducted in a random and unpredictable manner. This leads to no discernible P waves and an irregular rhythm with varying R to R intervals. Let's take a look at this strip to kind of give you a visual representation. So in atrial fibrillation, you have the irregular rhythm. So there's no progressive like lengthening as we saw in the type 1 Mobitz earlier. It's just kind of throwing out electrical impulses as the heart sees fit. The T waves are present, but there are no P waves. So you see that is how AFib will present on a lead. Now, choice B, complete AV block. That is a complete failure of impulse conduction from the atria to the ventricles. On the ECG, your P waves are going to be entirely unrelated to your QRS complexes, and they can be found before, after, or even within the QRS complexes. It's the top of the heart. It's not communicating with the bottom, so you have beats mixed in before, after on the lead. You're going to see a ventricular rate of less than 50 with faster atrial rate, a regular P to P and R to R interval, and complete dissociation of P waves and QRS complexes. Additionally, you may have wide QRS complexes, which is known as a junctional escape rhythm. So if this is our P to P, this is this interval, and then this would be our R to R. So as you see, there's no association between P waves and QRS complexes in third degree, which is complete AV block. And then C, first degree atrioventricular block, is due to delayed impulse transmission from the atria to the ventricles, leading to a prolonged PR interval, which is greater than 0.20 seconds. The PR interval remains constant, and a QRS complex follows every P wave. So this is what first degree AV block is going to look like. So you have the regular rhythms with constant R to R intervals. P waves always precede the QRS complex. There's no drops. And prolonged PR interval will be seen, which is more than those 5 tiny second squares. Okay, so for the educational objective, Mobitz type 1 atrioventricular block is recognized by progressive prolongation of the PR interval, followed by a dropped QRS complex. The block typically is located within the AV node. Patients with Mobitz type 1 AV block usually are asymptomatic, and management involves observation and correction of reversible causes. Okay, on to question 3. A 48-year-old woman presents with progressive shortness of breath and cough. The patient can hardly walk a block without having to stop due to dyspnea. She has a history of heart murmur and joint pains as an adolescent. Blood pressure is 110/70, and pulse is 110 beats per minute. Echocardiography shows thickening of the mitral valve leaflets and a restricted mitral valve opening. Which of the following is the most likely finding on physical examination for mitral stenosis? So this is going to be an assessment question. What are you going to find on your assessment? A, high-pitched blowing holosystolic murmur at the cardiac apex. B, high-pitched diastolic murmur at the left lower sternal border. C, low-pitched diastolic murmur at the cardiac apex. Or D, noisy systolic murmur at the right upper sternal border. And I'll give you a few seconds to review the question and the answer choices. The answer to this question is going to be C, a low-pitched diastolic murmur at the cardiac apex. Okay, so let's scroll down so I can get this picture to blow up. So these are the different locations of murmurs. This is a good image to save for your flashcards that we discussed last time. Down here, you could either click New Flashcard. If you already kind of have a cardiology grouping of flashcards, you add it to existing. And then My Notebook is for those who want to paste that image into a type of Word document where you can type your own notes. So for this one, it's heard. It is a low-pitched diastolic murmur at the cardiac apex, which is going to be down here for you to be able to see the entire image. So this is where you're going to note that sound. Diastolic murmurs are going to be mitral stenosis. Systolic murmurs are going to be mitral regurgitation and mitral valve prolapse in the apex area. So let's go over to our explanation. This patient's clinical features, which is that progressive dyspnea, cough, history of joint pains, and heart murmur in adolescence, and their echocardiographic findings, which is that restricted mitral valve opening, is going to be consistent with a rheumatic mitral stenosis. Cardiac auscultation in patients with mitral stenosis indicates a loud S1, an early diastolic sound after S2, which is that opening snap, and a characteristic murmur. So let's take a look at UWorld's image or video for the mitral stenosis. Okay. So very characteristic sound for the mitral stenosis murmur. It's a low pitch, as you heard, diastolic rumble, best heard using the bell of your stethoscope. So bell is for low pitch, the diaphragm is for higher pitch. Of the it's going to be located at the cardiac apex, which is the mid-clavicular line at the fifth intercostal space, with the patient lying on the left side, which is known as the left lateral decubitus position, and having their breath held after they blow out, and then you have them hold it. So you can really have the heart push forward. You can hear that silence, and you'll hear that with the opening snap. Choice A, which is the high-pitched blowing holosystolic murmur at the cardiac apex, is what's going to be a mitral regurgitation. So since it is high-pitched, it's at the right location, but it's the wrong sound. So this is what mitral regurgitation is going to sound like in comparison to the stenosis. Okay, so you don't hear that opening snap at all, and it's a higher pitch sound. B, a high-pitched diastolic murmur at the left lower sternal border. That's going to be heard in patients with aortic regurgitation. Where that differs is that the mitral stenosis is going to be heard at the cardiac apex. Aortic regurgitation is going to be heard at the left lower sternal border. Let's take a listen to aortic regurgitation. Oh. Let's see, I think you guys got kicked out. Let's get you back in. Hmm. Okay, sorry about that. We left on aortic regurgitation. Yeah. Now, choice D. A noisy systolic murmur heard at the right upper sternal border is typical in patients with aortic stenosis. Isolated and uncomplicated microstenosis does not cause systolic murmur. A 1-month-old boy is seen because when he is nursing, he becomes diaphoretic. And for the past week, he has only fed for only 5 minutes at a time before falling asleep. Examination shows a thin infant who is sleeping but easily arousable. Cardiac examination reveals tachycardia with a 1 out of 6 systolic murmur over the left lower sternal border and diastolic rumble over the cardiac apex. The S2 is prominent. There is no clubbing, cyanosis, or peripheral edema. Which of the following is the most likely diagnosis? So this is a diagnosis question. A, atrial septal defect. B, mitral stenosis. C, transposition of the great precipice. And D, ventricular septal defect. I'll give you guys a few minutes or seconds to answer the questions. This particular answer is going to be D, ventricular septal defect. Now, this is another good image to study with your flashcards. Zoom in a little bit. So as you can see, here you have the deoxygenated blood, which is blue, and over here it is the oxygenated red blood. And when you have a VSD, a ventricular septal defect, there is mixing of the deoxygenated blood and oxygenated blood, creating this kind of purple on this image. This is a good image to kind of keep in your mind for you to remember how does that look and why does it cause the dyspnea due to lack of oxygenated blood going to the body. So let's take a look at the definition. This patient's examination is most consistent with a large ventricular septal defect, a common congenital heart malformation. VSDs range from small and asymptomatic to large with significant left to right symptoms. Features are going to be polycystic murmur at the left lower sternal border. Small or moderate VSDs produce 2 to 6 grade polysystolic murmurs due to turbulence. In contrast, large VSDs are quieter due to low resistance, therefore less turbulence, through a larger orifice. An apical diastolic rumble may also be heard to increase flow across the mitral valve as a result of that left to right shifting. And a right ventricular pressure increase will occur due to increased flow. That S2 becomes more prominent due to increased pressure closing of the pulmonary valve. Let's take a listen. Or actually, this is going to be kind of an image where the murmur is going to get off the tunnel. Okay. So let's take a look at the reason why the other answer choices are incorrect. Choice A, the atrial septal defect. A large atrial septal defect can cause tachypnea. However, it will lead to a widening of fixed ST, which is not present in this patient. Choice B, mitral stenosis. Mitral stenosis can also cause an apical diastolic rumble, but it will not be hollow systolic and won't be oscillated at the left lower sternal border. And then choice C, position of the great vessels, which is characterized by the aorta arising from the right ventricle and the pulmonary artery arising from the left ventricle. So transposed, it would cause cyanosis, which is not seen in this patient. So this is what that would actually look like. Okay. And then on to question 5. A 32-year-old woman has had palpitations for the last hour. She describes prior episodes of similar palpitations that usually last 10 to 15 minutes and terminate spontaneously. The patient is otherwise healthy. Blood pressure is 115/70. Lungs are clear to auscultation, and cardiac examination is notable only for tachycardia. ECG is shown in this exhibit. Which of the following is the best initial treatment for this patient's condition? So this is a plan question. Let's take a look at the exhibit. So this is what the patient's 12-lead ECG is going to look like. Now the answer choices for this would be, and this is also best initial treatment for this patient's condition. A, amiodarone. B, carotid sinus massage. C, conscious sedation and cardioversion. Or D, lidocaine. So let's take a look at the exhibit, give you guys a couple of seconds to kind of figure out what you would do, and we'll move on. The answer to this question is B, carotid sinus massage. Now we'll come back to this ACLS guideline for management of adult with tachycardia. So let's take a look at the explanation. This patient's electrocardiogram shows a regular, narrow QRS complex tachycardia consistent with SVT, or supraventricular tachycardia. This is one of the most common forms. The atrioventricular nodal reentrant tachycardia is a common form of sustained paroxysmal supraventricular tachycardia. Other features of SVT may include constant R-to-R intervals and retrograde P waves. These patients are going to present with palpitations, but they may also have lightheadedness, shortness of breath, diaphoresis, chest pain, pre-syncope, or syncope. In patients that are hemodynamically stable, the next step is going to be to attempt to you would try IV adenosine, which will also impair the AV nodal conduction, and that's the preferred farm agent for stable patients. But you still want to try the non-pharmaceutical vagal maneuver first. Okay, so choice A, amiodarone. Actually, before we get to why the answers are incorrect, let's take a look at this strip. Rate is usually going to be greater than 150 beats per minute, but it's going to be a regular rhythm. P waves are often not visible because they're buried in the QRS or T waves, and abnormal shape is going to be seen if they are visible. So another great strip to add to the flashcards for you to be able to recognize on site. Okay, now amiodarone. It is a class 3 antiarrhythmic drug that's occasionally used for the acute management of ventricular arrhythmias and maintenance of sinus rhythm in patients with AFib. However, it has no role in the management of patients with regular, narrow, complex tachycardia, which is why this answer is incorrect. C, conscious sedation and cardioversion. Patients with persistent tachyarrhythmia, narrow or wide complex, that causes hemodynamic instability should be managed with immediate synchronized direct current cardioversion. So instability is going to look like hypotension, altered mental status, shock. These patients need something done immediately because they're hemodynamically unstable. Since this patient just kind of just had palpitations, she's stable, she's healthy, blood pressures look good, she doesn't require a cardioversion. Also, because cardioversion requires kind of getting the heart rate back to where it should be, it's quite painful. So you don't want to use it unless you have to. Choice D, lidocaine. That is a class IV antiarrhythmic that is used to treat ventricular arrhythmias. It's often used in the treatment of hemodynamically stable patients with wide QRS complex tachycardia, but not recommended for this patient that has a narrow complex SVT. So the educational objective for this question, stable patients with regular narrow complex tachycardia should be hemodynamic instability should be managed with immediate synchronized direct current cardioversion. I don't know if you guys heard that last part, but just make sure that your patients that have persistent tachyarrhythmia, whether narrow or wide, causing hemodynamic instability, should be managed immediately with cardioversion. Okay, so this is the end of our question portion of the live. Again, if you want to review those other two lives, um, they are online on YouTube on our page. This one will also be available on our page. And if we have any lives going forward, feel free to subscribe to our page. Make sure that notifications are active so that you receive any notifications of any update of lives for you to view. And until then, I'll see you next time.